Millions of people over the age of 60, people living normal lives, managing familiar routines, reaching for the same bottles they have reached for 100 times before, are quietly developing kidney damage that is almost entirely preventable. This is not a rare side effect happening to a small, unusual group of patients. It is happening at a scale that should concern every adult in this country who has ever taken a common, over-the-counter painkiller without a second thought. This is not a distant problem. It is happening in kitchens, in living rooms, and in bedrooms across the country right now. And the most alarming part is that there are almost no warning signs. Kidneys do not send pain signals the way a sprained ankle does, the way a headache announces itself. They simply begin to fail quietly while a person goes about their day feeling more or less fine. If you are over 60 or love someone who is, what follows in this video may be the most important health information you hear this year. Hi, I'm Dr. Arthur Bennett, and I am going to show you what is happening, why it matters, and exactly what you can do. And you are far from the only one navigating this without realizing the risk involved. The painkiller at the center of this conversation is one you almost certainly have in your home right now. It sits in medicine cabinets across every zip code in this country. It is recommended on packaging that looks safe, sold at every pharmacy, grocery store, and gas station convenience counter without a prescription. It is a class of drug known as NSAIDs, non-steroidal anti-inflammatory drugs, and the most familiar names in that family are ibuprofen and naproxen. You probably know them as Advil, Motrin, or Aleve. For decades, these medications have been positioned as the dependable, accessible answer to everyday pain. Backaches after a long day, arthritis flare-ups in the morning, headaches, joint stiffness, the kind of persistent soreness that comes with age. For a generation that built their lives on self-sufficiency and doing things the practical way, reaching for the bottle that promises relief makes complete sense. It feels responsible. It feels like taking care of yourself. But here is what most people in this age group were never told and what the pharmaceutical messaging never highlighted. NSAIDs work by blocking a specific set of enzymes called COX enzymes, which are responsible for producing the prostaglandins that create inflammation. That sounds straightforward enough. The problem is that those same prostaglandins play a critical role in maintaining blood flow to the kidneys. The kidneys rely on them as a kind of internal pressure regulator. When you are young and your cardiovascular and renal systems are operating with full reserve capacity, the disruption that NSAIDs cause to this process is usually manageable. Your body compensates. But as the body ages, and we will talk specifically about why the over 60 body responds so differently, that reserve capacity shrinks. The kidney's ability to compensate for reduced blood flow becomes increasingly limited. And this is where repeated casual NSAID use begins to cross a line that millions of people do not even know exists. When researchers first began examining the population-level relationship between NSAID use and kidney function in older adults, the findings were not subtle. The data pointed to a consistent, measurable pattern of harm, not in people doing something unusual or risky, but in people doing exactly what they were told was fine. What this means for people at this stage of life specifically changes what we need to discuss next. The pattern across the population, once you see it, is remarkably consistent. And that consistency is both medically significant and deeply important for every person watching this. When public health researchers began tracking NSAID-related kidney outcomes across different communities and age groups, a clear picture emerged. The risk was not evenly distributed. It was concentrated heavily in adults over 60. And within that group, the risk increased with something most people consider completely ordinary behavior, a regular, repeated use.
Not overdose.
Not misuse. Simply taking the recommended dose consistently over time because the pain kept coming back and the pills kept working. That is the specific behavioral pattern that the population-level data kept identifying. A person develops arthritis in their knees. The pain is real and limiting. They take ibuprofen because it helps. It does help. So they take it again the next day and the day after that. Weeks pass, months. A bottle gets replaced when it runs out. No one flags it as a problem because no one is looking closely enough at what is quietly building beneath the surface. The kidneys, meanwhile, are functioning under a kind of sustained pressure. The prostaglandins that help regulate renal blood flow are being suppressed on a near daily basis. The kidneys are adapting as best they can, but adaptation has limits. And in population-level studies, the people who used NSAIDs most regularly over longer periods showed measurably accelerated decline in kidney function compared to those who used them infrequently or not at all. This was true even after researchers accounted for other risk factors. Even when they controlled for diabetes, hypertension, pre-existing kidney conditions, the NSAID use on its own was independently associated with kidney function decline. For a generation that was taught to trust these medications, that grew up seeing them advertised on television as the sensible, reliable choice, the data represents a difficult correction to absorb. Many people who reached adulthood in the 1970s and 1980s remember when ibuprofen first became available over the counter and was celebrated as a medical breakthrough. It was liberating. You no longer had to see a doctor for pain relief. You could handle it yourself. That cultural memory is still shaping behavior today. And it is one of the reasons the pattern persists at population scale. Not because people are being reckless, but because they are following habits that were formed in a different era with a different understanding of long-term risk. The pattern does not stop there. There is a second layer to this that affects this age group even more directly. What makes this age group specifically vulnerable goes beyond habit. It goes into biology. And understanding it is what turns this from a general health concern into something personally actionable. The kidneys of a 65-year-old are not the same as the kidneys of a 35-year-old. Even in healthy older adults, kidney function naturally declines with age. By the time most people reach their mid-60s, they may have already lost 20 to 30% of their peak kidney filtration capacity. And many do not know this because standard kidney function tests often fall within the broad, normal range, even when meaningful decline has occurred. This is not disease. This is biology. But it creates a vulnerability that dramatically changes how NSAIDs affect the body. Because when you begin with reduced reserve capacity, the disruption that NSAIDs cause to renal blood flow has far less cushion to work within. The margin of safety shrinks. And when other age-related factors are layered on top of that, lower fluid intake, which is extremely common in older adults who often experience a diminished sense of thirst, age-related changes in how medications are metabolized and cleared by the body, the presence of other conditions like mild hypertension or early cardiovascular changes, that margin shrinks further still. Among the adults most frequently studied in this context, people in their 60s and 70s managing chronic pain conditions with over-the-counter NSAIDs, the progression toward what clinicians call chronic kidney disease often happened gradually and without any clear trigger event. There was no dramatic moment. No acute crisis, just a slow, sustained erosion of function that only became visible when it had already advanced significantly. Many people in this generation were also raised with a strong sense of not wanting to bother anyone, not wanting to be seen as complainers. There is something deeply embedded in that worldview, a stoicism around health that made enduring pain feel virtuous and that made reporting new symptoms feel like weakness. That cultural value, which served people well in many contexts, becomes a liability when the condition doing the damage produces no symptoms worth reporting. The kidneys give almost no warning. They do not ache the way joints do. They do not swell visibly. They do not create the kind of obvious signal that sends someone to a doctor before significant damage has already occurred. By the time fatigue becomes noticeable, by the time swelling appears in the ankles or legs, by the time blood pressure begins to climb in ways that require medical attention, kidney function may already be substantially compromised. And what the community-level data shows next is where the real opportunity for change becomes clear. What most people in this community do not yet know, and what represents the most critical gap in public health awareness around this issue, is the specific threshold problem that makes NSAID use in older adults so different from NSAID use in younger populations. The threshold problem works like this. In younger adults, the relationship between NSAID use and kidney risk is relatively dose-dependent, meaning the risk scales with how much you take and how often. But in older adults, the threshold at which risk begins to accumulate is significantly lower. Research examining population-level outcomes consistently found that older adults could reach meaningful kidney stress thresholds with doses and durations that would be considered moderate, not excessive, in a younger person. This means the mental framework most people carry around NSAIDs, the idea that taking a recommended dose occasionally is fine and only extended heavy use creates problems, is not accurate for this age group. The math has changed, but the public messaging has not caught up. And this is compounded by something that health professionals see regularly in clinical settings, the issue of concurrent use without awareness. When people over 60 take ibuprofen for pain, while also taking blood pressure medications, diuretics, or other commonly prescribed drugs for age-related conditions, the interaction between those substances can significantly amplify renal stress. Certain blood pressure medications, particularly ACE inhibitors and ARBs, which are among the most commonly prescribed drugs in this age group, interact with NSAIDs in a way that creates what clinicians sometimes describe as a triple whammy effect on the kidneys. The combination of reduced prostaglandin activity from the NSAID, blood volume changes from diuretics, and the mechanism of ACE inhibitors or ARBs creates a compounding pressure on renal blood flow that is substantially greater than any one of those factors alone. This is not a rare clinical scenario. This is happening in the daily medication routines of millions of older adults who are simply managing multiple conditions the way their doctors prescribed. And adding an over-the-counter painkiller without realizing it changes the equation in a meaningful way. Think about the routines many people have built over the years. A blood pressure pill in the morning, a water pill if the doctor recommended it, and on the days when the knees or back or shoulders are bad, which for someone managing arthritis might be most days, ibuprofen as well. This combination, repeated across weeks and months, represents one of the most under-recognized risks in senior health today. What the community-level data shows next is where the real opportunity for change becomes clear. When health professionals and researchers began looking not just at what causes harm, but at what actually works, what real people in this age group are doing to manage chronic pain without putting their kidneys at risk, the findings were both encouraging and, in many cases, genuinely surprising. And this is the part of the conversation I find most energizing, because the solutions here are real, practical, and supported by solid evidence at population scale. I want to ask you something, and I genuinely want to know, how many people in your life, family members, close friends, neighbors, people you see at church or at the grocery store, do you think are taking NSAIDs regularly right now for chronic pain without any awareness of what it might be doing to their kidneys? Give me a number in the comments. Even a rough estimate. Because those numbers, added together from everyone watching this video, tell us something important about how widespread this really is, and why this conversation needs to keep happening. Now, what works? The first thing the evidence supports clearly is a shift toward acetaminophen, known as Tylenol, as a first-line pain management option for many older adults. Acetaminophen does not carry the same renal risk profile as NSAIDs. It works through a different mechanism. It does not affect prostaglandins. It does not reduce renal blood flow. For mild to moderate pain, the kind that might typically prompt someone to reach for ibuprofen, acetaminophen, used correctly and within recommended doses, is frequently a safer alternative for kidney health. The critical word there is correctly, because acetaminophen does carry its own risks, particularly for the liver when used in excessive doses or combined with alcohol. But at appropriate doses, it represents a meaningful harm reduction step for many people in this age group. Beyond medication choices, the population-level data on non-pharmacological approaches has become increasingly compelling. Regular, low-impact physical activity, swimming, walking, gentle cycling, has shown consistent results in reducing chronic pain intensity in older adults with musculoskeletal conditions. Not eliminating it, but reducing it meaningfully. Physical therapy, specifically targeted to individual pain conditions, has shown outcomes in some studies that rival or exceed those of regular NSAID use without the systemic risks. Topical NSAIDs, which are applied directly to the skin over a painful joint rather than taken orally, represent another option that many people in this community have not been told about. Because they work locally rather than systemically, the amount that reaches the bloodstream, and therefore the kidneys, is dramatically lower than oral forms. Heat therapy, cold therapy, acupuncture, and specific dietary adjustments that reduce systemic inflammation are all part of a growing evidence base that points toward a more comprehensive, lower-risk approach to chronic pain management in older adults. What the community-level data shows next is where the real opportunity for personal action begins. What you can do, starting right now, does not require a medical degree, a specialist referral, or anything complicated. It begins with one decision: to treat your pain management routine with the same seriousness you would give any other aspect of your long-term health. The first step is a medication review. If you are regularly taking any NSAID, ibuprofen, naproxen, or even prescription-strength anti-inflammatories, and you are over 60, the most important thing you can do this week is have a direct conversation with your doctor about your kidney function. Ask specifically about your GFR, your glomerular filtration rate. This is the number that most accurately reflects how well your kidneys are filtering your blood. It is calculated from a standard blood test, and it is not always reviewed proactively unless you ask. Many older adults have never seen this number. Many would not know what to ask for, but knowing your GFR baseline is one of the most powerful pieces of information you can have when it comes to making informed decisions about any medication that carries renal risk. When you speak with your doctor, bring your full medication list, including every over-the-counter drug you take regularly. Be specific. Include the painkiller you take for your knee. Include the supplement. Include everything. Across the people most at risk for this kind of harm, one of the most consistent findings is that over-the-counter medications simply are not being reported to physicians because patients do not realize they matter. They do. They matter significantly. Ask your doctor 2 specific questions. First, given my current kidney function and my other medications, is it safe for me to be taking NSAIDs regularly? Second, what alternatives would you recommend for managing my pain that carry less renal risk? Those 2 questions alone can change the trajectory of your kidney health in ways that are meaningful and lasting. At home, hydration is a practical step you can take immediately. NSAIDs are more harmful to the kidneys when the body is even mildly dehydrated. And mild dehydration is extremely common in older adults who do not feel thirst the way younger people do. Making a conscious effort to drink adequate water throughout the day, not just when you are thirsty, creates a more favorable environment for your kidneys regardless of what else you are doing. This is simple, it costs nothing, and it reduces risk in a measurable way. Be the person in your household, in your family, in your circle of friends who starts asking these questions out loud. Because when one person asks, others begin to ask too. And what the community-level data shows consistently is that awareness spreads, and when it does, outcomes improve. What follows now is the close, and it is the part of this conversation I want you to carry with you. Together, through this video, you have just built an understanding that most people in your community do not yet have. You came in perhaps vaguely aware that painkillers had some risks. You are leaving with something much more specific and much more useful, an understanding of the mechanism, the population level pattern, the biological reasons your age group is especially vulnerable, and a set of concrete evidence-based actions you can take starting this week. That is not a small thing. That is the difference between a health risk that continues quietly in the background and one that gets interrupted by information, by conversation, by a single phone call to a doctor's office to ask about your GFR. You are now equipped with something real. And real knowledge shared with real people creates real change. The people in your life, your spouse, your siblings, your friends from your neighborhood or your church or the group you walk with in the mornings, they are dealing with chronic pain too. Most of them are reaching for the same bottles. Most of them have never been told what you now know. Sharing this video with one person, just one, puts this information into another home, another medicine cabinet, another conversation. That ripple matters. I want this community of people, everyone who watches this channel, to genuinely thrive. Not just individually. Together, Because the health challenges that face people in this stage of life are real and significant, but they are not inevitable. Information changes outcomes. Community changes outcomes. A generation that faced hard things with resilience and practicality throughout their lives has every tool they need to face this one the same way. With clear eyes and good data. Share this video with your community today, a family member, a close friend, a neighbor who could use this. Leave your estimate in the comments because that number matters and I read everyone. And stay with us because every video we make is built for exactly this community, for exactly you, and for the genuine goal of helping you and the people you love live longer, healthier, and more fully.